Bismillahirrahmanirrahim. Quote of the day: happiness is found when you stop comparing yourself to other people. Today, the topic of my presentation is dengue fever, and I'm presenting it under supervision of my professor, Dr. Sarah Afzal. Learning outlines, case presentation, global burden, epidemiological determinants, classification of dengue, laboratory diagnosis, treatment, prevention, control, dengue situation in Pakistan, and recent updates and MCQs in the end. Learning outcomes. By the end of this presentation, participants would be able to describe epidemiological determinants, laboratory diagnosis, prevention, treatment of dengue fever. This is a case scenario. A 30-year-old male with no significant past medical or surgical history presented to the emergency department, complaints of fever, headache, retroorbital pain, myalgia of 1 week duration. The patient reported high-grade intermittent fever for the past 7 days that was associated with rigors and chills. His other complaints included reddish-colored urine with clots for 2 days, along with 2 episodes of gum bleed. On physical examination, the patient was vitally stable, oriented to person, place, and time, and had mild conjunctival pallor. On skin examination, there were multiple purpura petechiae on the left shoulder, trunk, legs, and 2 large ecchymosis lesions on the patient's back. Rest of the systemic examination was unremarkable. The baseline workup done in the emergency department was normal except for a low platelet count of 20,000 and a low platelet and a low WBC count. His chest X-ray was normal. 3 malaria smears were negative. Blood culture showed no growth. However, there was positive dengue-specific IgM with a value of 1.94 on ELISA. So the differential diagnosis pointing toward this case scenario were dengue fever, malaria, typhoid, urinary tract infection. Problem statement. Dengue virus has spread to people through the bite of infected Aedes species, that is Aedes aegypti or Aedes albopictus of mosquito. These mosquitoes also spread Zika, chikungunya, and other viruses. Dengue is found in tropical and subtropical climates worldwide, mostly in urban and semi-urban areas. The global incidence of dengue has grown dramatically, with about half of the world's population now at risk. Each year, up to 400 million people get infected with dengue. Approximately 100 million people get sick from infection, and 40,000 die from severe dengue. Dengue is caused by one of the 4 related viruses, dengue 1, 2, 3, 4. For this reason, a person can be infected with a dengue virus as many as 4 times in his or her lifetime. Distribution and outbreaks. The disease is now endemic in more than 100 countries in WHO regions of Africa, America, Eastern Mediterranean, Southeast Asian, Western Pacific. The Americas, Southeast Asian, Western Pacific regions are the most seriously affected, with Asia representing almost 70% of the global burden of disease. The large number of dengue cases ever reported globally was in 2019. All regions were affected and dengue transmission was recorded in Vietnam for the first time. The American region alone reported 3.1 million cases, with more than 25,000 classified as severe. Despite this alarming number of cases, deaths associated with dengue were fewer than the previous year. High number of cases were reported in Bangladesh, Malaysia, Philippines, Vietnam, and Indonesia. In 2020, dengue affected several countries, with reports of increase in the number of cases in Bangladesh, Brazil, and all these regions. The COVID-19 pandemic is placing immense pressure on healthcare and management systems worldwide. WHO has emphasized the importance of sustaining efforts to prevent, detect, and treat vector-borne diseases during this pandemic, such as dengue and other arboviral diseases. As case number increases in several countries and place urban population highest risk for both diseases. The combined impact of the COVID-19 and dengue epidemics could have devastating consequences on the populations at risk. So this is a map showing the burden of dengue fever worldwide, and we can see that the highest burden or prevalence is seen in this Asia regions, followed by America and other areas. Epidemiological determinants. Agent factors. The dengue virus form a distinct complex with the genus Flavivirus based on antigenic and biological characteristics. There are 4 virus serotypes which are designated as Dengue 1, 2, 3, and 4. Infection with any one serotype confers lifelong immunity to that virus serotype. Secondary infection with dengue serotype 2 or multiple infection with different serotypes lead to severe form dengue hemorrhagic fever, or dengue shock syndrome. Vector. Dengue is transmitted to people by the bite of an infected yellow fever mosquito Aedes aegypti or the Asian tiger mosquito Aedes albopictus, which are found in tropical and temperate zones throughout the world. Now, host. These are the host factors that age. It is common in all groups, but in Southeast Asian children are more affected. Pre-existing anti-dengue antibody are found in previous infection maternal antibodies. High risk in secondary infections. High risk with 2 or more serotypes circulating simultaneously. Host genetics race white may be great risk than black, and virus strain, certain genetic strain virus causes dengue in primary infection. Infective stage is 1 day before onset of fever to day 5. And intrinsic incubation period is 4 to 6 days. And these are the high-risk patients, that is extremes of age, pregnancy, any condition prone to heavy blood loss like peptic ulcer disease, hemolytic anemia, J6PD deficiency, thalassemia. Environmental factors. The population of Aedes aegypti fluctuates with rainfall and water storage. Its lifespan is influenced by temperature and humidity, survives best between 16 to 30 degrees centigrade and a relative humidity of 60 to 80%. It breeds in the container in and around the houses. So this is the cycle to show that how dengue is spread. First, this mosquito bites dengue infected person, then mosquito ingests blood with dengue virus, take 8 to 10 days for dengue virus to incubate. Then dengue infected mosquito bites another person, and that person gets dengue 4 to 13 days later. Clinical features. These are the common signs and symptoms. These symptoms are fever, headache, muscle pain, and in this dengue fever, is such a severe muscle and bone pain that is called bone breaking fever. Then we have retroorbital pain, arthralgia, anorexia, nausea, diarrhea, vomiting, fatigue, cough, and signs we see are rash, fatigue, swollen red hands, and hepatomegaly. There are 3 types of dengue fever: classical dengue hemorrhagic fever, dengue shock syndrome. This is the criteria for clinical diagnosis of these 3 types. First, we have dengue fever. Probable diagnosis in this acute febrile illness with 2 or more of the following: headache, retroorbital pain, myalgia, arthralgia, rash, hemorrhagic manifestations, leukopenia, thrombocytopenia, and at least one of the following: supportive serology on single serum sample, and occurrence at the same location and time as confirmed cases of dengue fever. Confirmed diagnosis is made when probable case with at least one of the following, that is isolation of dengue virus from serum, CSF or autopsy samples, 4-fold or greater increase in serum IgG or increase in IgM antibodies specific to dengue virus, detection of dengue virus or antigen in tissue, serum or CSF by immunohistochemistry or ELISA, or detection of dengue virus genomic sequences by reverse transcription. So when probable case is accompanied with any of the following this laboratory test, then we label it as confirmed diagnosis, confirmed dengue fever. Dengue hemorrhagic fever. All of the following. It is characterized by acute onset of fever of 2 to 7 day duration. Hemorrhagic manifestations shown by any of the following, like positive tourniquet test, fatigue, ecchymosis, purpura, bleeding from mucosa, GIT, injection sites, or other location. In this, we have platelet count of less than 100,000 cells per cubic meter. Objective evidence of plasma leakage due to increased vascular permeability is shown by any of the following. It is rising hematocrit or hemoconcentration greater than 20% from baseline, or evidence of plasma leakage such as pleural effusion, ascites, or hypervolemia. So this all is the characterization of dengue hemorrhagic fever. Then the third type is dengue shock syndrome. Criteria for dengue hemorrhagic fever as above, with signs of shock, including tachycardia, cold extremities, delayed capillary refill, weak pulse, lethargy, less trace, Pulse pressure less than 20 mmHg with increased diastolic pressure that is 100 by 80 mmHg. Hypotension by age defined as systolic pressure less than 80 mmHg for aged less than 5 years or 80 to 90 mmHg for older children and adults. Current diagnostic tests with pros and cons, these are the most commonly used tests for the laboratory confirmation. First, we have virus isolation. It is used for its specificity and reliable results. However, disadvantages are time consuming, lower sensitivity, expensive, and laborious steps. Then we have PCR technique, which has high sensitivity, high specificity, and results less than 24 hours and reliable results. Then we have NS1 detection, which is inexpensive, rapid results, and easy to prepare. Then we have serology tests, IgG and IgM, which is inexpensive, rapid results, and easy to operate. However, the disadvantages we have are lower sensitivity and high cross reactivity with other flavivirus. So this is the here we can see that this is the day of illness. For the first 5 days, we can go for serum PCR assay for first 5 days of illness. And for the first 7 days of illness, we usually recommend NS1. After that, we recommend IgM, and by the end of the first week there is a rise in IgG in primary infection. However, there is rise in IgG in secondary infection from the starting from the 5th day of the illness. So initially we go for PCR and NS1 for the first 5 to 7 days of illness. Treatment. There is no specific treatment for dengue fever. Patients should rest, stay hydrated, and seek medical advice. Depending on the clinical manifestation or the circumstances, patient may be sent home, be referred for in-hospital management, or require emergency treatment. Urgent temporal supportive care such as fever reducers and painkillers can be taken to control the symptoms of muscle aches and pains and fever. The best option to treat these symptoms are acetaminophen and paracetamol. The most important thing to remember is that NSAIDs such as ibuprofen and aspirin should be avoided, as these anti-inflammatory drugs act by thinning the blood, and in disease with risk of hemorrhage, blood thinners makes evade the prognosis. For severe dengue, medical care by physicians and nurses experienced with the effects and progression of disease can save lives, decreasing mortality rates to less than 1% in majority of the countries. Prevention and control. If you know you have dengue, avoid getting further mosquito bites during the first week of illness. Virus may be circulating in the blood during this time and therefore may transmit the virus to new uninfected mosquitoes who may in turn infect other people. The proximity of mosquito vector breeding sites to human habitation is a significant risk factor for dengue. At present, the main method to control or prevent the transmission of dengue virus is to combat the mosquito vectors. This is achieved through prevention of mosquito breeding. This is done by preventing mosquitoes from accessing egg-laying habitat by environmental management and modification, disposing of solid waste properly and removing artificial man-made habitats that can hold water, covering, emptying, and cleaning of domestic water storage containers on a weekly basis, applying appropriate insecticides to water storage outdoor containers. Then the second method is personal protection from mosquito bites by using of personal household protection measures such as window screens, repellents, coils, reprisers. These measures must be observed during the day, both inside and outside of the home, because the primary mosquito vector bites throughout the day. Wearing clothes that minimize skin exposure to mosquitoes is advised. That is long sleeves and full trousers. These are the insect repellents that are recommended by CDC, which are proven safe and effective even for pregnant breastfeeding women. These are DET, Precardin, oil of lemon, eucalyptus, paramethanol, diol. Community engagement. Educating the community on the risk of mosquito-borne diseases, engaging with the community to improve participation and mobilization for sustained vector control. Active mosquito and virus surveillance. Active monitoring and surveillance of vector abundance and species composition should be carried out to determine effectiveness of control interventions. Prospectively monitor prevalence of virus in the mosquito population with active screening of sentinel mosquito collections. Vector surveillance can be combined with clinical and environmental surveillance. In addition, there is ongoing research among many groups of international collaborators in search of novel tools and innovative strategies that will contribute in global efforts to interrupt transmission of dengue. The integration of vector management approach is encouraged by WHO to achieve sustainable, effective, locally adopted vector control interventions. So this is the WHO response to dengue. This is how it responds in the following ways. It supports countries in the confirmation of outbreaks through its collaborating network of laboratories, provides technical support and guidance to countries for the effective management of dengue outbreaks, supports country to improve the reporting system and capture the true burden of the disease, provides training on clinical management, diagnosis, and vector control at the country and regional level with some of its collaborating centers, formulates evidence-based strategies and policies, support countries in the development of dengue prevention control strategies and adopting the global vector control response. It reviews the development of new tools, including insecticide products and application technologies. It gathers official records of dengue and severe dengue from over 100 member states and publishes guidelines and handbooks for surveillance, case management, diagnosis, dengue prevention, and control for member states. Now, coming towards vaccination against dengue, the first dengue vaccine, Dengvaxia. This was developed by Sanofi Pasteur, was licensed in December 2015 and has now been approved by regulatory authorities in almost 20 countries. In November 2017, the results of additional analysis to respectively determine zero status at the time of vaccination were released. The analysis showed that the subset of trial participants who were inferred to be seronegative at time of first vaccination had a higher risk of more severe dengue and hospitalizations from dengue compared to unvaccinated participants. As such, use of this vaccine is targeted for persons living in endemic areas, 9 to 45 years of age, who have at least one episode of dengue virus infection in the past. And there are several other vaccine candidates in the development, including live attenuated inactivated DNA and subunit vaccines. Vaccine eligibility. Children and adolescents 9 to 16 years old with laboratory confirmation of previous dengue virus infection and living in dengue endemic areas are eligible for the dengue vaccine. It requires 3 doses and can prevent dengue illness, hospitalization, and severe dengue from all 4 dengue viruses. The main point to remember is that do not vaccinate a person without laboratory evidence of previous dengue virus infection. In persons who have not dengue before, the vaccine would increase the risk of hospitalization or severe dengue if a person gets dengue after vaccination. If you vaccinate a person who has never been infected with dengue virus, they skip the first natural infection. If the person is then infected after vaccination, they will experience infection that is similar to the second dengue virus infection, which poses the highest risk of severe disease. And the mechanism causing greater severity of the second dengue virus includes antibody-dependent enhancement, which can lead to plasma leakage and severe disease. Vaccinate a person with laboratory evidence of previous dengue virus infection. If you vaccinate a child who has been previously infected with dengue virus, the child skips the second dengue virus infection. If infected after vaccination, the child will experience infection that is similar to the third or fourth dengue virus infection, which are the lowest risk for severe disease. So for vaccinating a person, we should know the immune status by going through the pre-screening laboratory methods like pre-vaccination screening for previous dengue virus infection. Laboratory confirmation of previous dengue virus infection is required and can be obtained by evidence of a prior acute dengue virus infection with positive PCR result, a positive dengue NS1 antigen test, a positive test results on pre-vaccination screening test. Vaccine schedule and dosing. The dengue vaccine requires 3 doses administered subcutaneously and given 6 months apart for full protection. And it is given through subcutaneous route. Vaccine administration after dengue virus infection. Children and adolescents with dengue should wait at least 6 months after the date the dengue infection is confirmed to begin the vaccine series. Vaccine safety and efficacy. Vaccine safety, it is when used in individuals with laboratory evidence of past dengue virus infection, the dengue vaccine is very safe. The most frequently reported side effects are headache, injection site pain, malaise, asthenia, myalgias. And it efficacy is among children 9 to 16 years old with previous dengue virus infection. It has an efficacy of about 80% against the outcomes of symptomatic virological confirmed dengue, hospitalization of dengue, and severe dengue. Duration of vaccine protection. Recent studies showed that dengue vaccine provides protection against hospitalization and severe disease for at least 6 years after the last dose of the series, but studies are still going on to determine how long protection may last. Pregnancy. Pregnant people were not specifically enrolled and studied in vaccine trials, although no significant difference in adverse pregnancy outcome between vaccinated and vaccinated people were found. The number of pregnant people enrolled was too small to determine the effect of dengue vaccine on pregnancy. However, vaccine providers should consider the risk of dengue virus infection when making a recommendation for vaccination for pregnant people, because pregnant people had increased risk of dengue-related complications. And there is no data available to evaluate dengue vaccine and breastfeeding. Vaccine availability. Dengue vaccine became commercially available in 2016 in 11 countries. These are Mexico, Philippines, Indonesia, Thailand, Singapore. In 2019, it was approved for medical use in the US. It is on the WHO's list of essential medicines. Dengue vaccines are not commercially available in Pakistan. The WHO recommends that countries should consider vaccination with dengue vaccine only if the risk of severe dengue in seronegative individuals can be minimized either through pre-vaccination screening or recent documentation of high seroprevalence rates in the area. Dengue during pregnancy. A pregnant woman already infected with dengue can pass the virus to her fetus during pregnancy or around the time of birth. Dengue can have harmful effects including death of fetus, low birth weight, and premature birth. Dengue during breastfeeding, it is very safe in breastfeeding. The risk of transmission of dengue virus from mother to baby through our breast milk is next to negligible. And according to guidelines by WHO, it is important to breastfeed the newborn during maternal dengue infection. Breast milk has a lot of nutrients and antibodies which help protect the baby, prevent dehydration, and maintain his overall well-being. Now, dengue fever in Pakistan. Dengue is endemic in Pakistan with the last notable outbreak with 53,498 cases and 95 deaths being reported between September to December 2019. From 1st Jan to 25 November 2021, a total of 48,906 cases, including 183 deaths. That is with case fertility ratio of 0.4% have been reported from 4 provinces. And as of 25th November, Punjab province reported the highest number of cases with 24,146 cases and 127 deaths, accounting for 49.4% and 69.4% of all cases and deaths respectively. And the deaths were mainly reported from Lahore district. Public health response Pakistan. The federal and provincial health departments are implementing public health measures, including the following: vector surveillance and control activities. As part of the integrated vector management, surveillance of Aedes larvae and space spraying activities are underway in Punjab province. Between 16 to 25 November, indices of Aedes larvae in all household percentage of that is household infested with larvae, pupae, and container indices have fallen below 2, which is less than the threshold of 5. With the opening of a field hospital in Lahore, fumigation and spot checks have been carried out in Rawalpindi and Islamabad city. Islamabad multi-sectoral coordinated activities including vector surveillance, larva source management, destruction of mosquito breeding sites, active case and contact finding, clinical management of patient waste management, door residual spraying, all have been launched to control the dengue outbreak. WHO country office supporting the government of Pakistan by undertaking following response activities: the strengthening of laboratory and hospital-based disease surveillance in all endemic provinces and at the national level, including existing opportunities of integrated disease surveillance, field epidemiology, and dengue surveillance cells; establish data and report collection center at WHO country office; trained healthcare providers from all endemic provinces and districts on the management dengue cases at various levels of healthcare delivery system, and providing training on vector surveillance and vector control, including source reduction during house visits at the regional level. Trainees included selected entomologists from national and provincial programs and academia, collaborated with partners and national provincial health ministries on raising community awareness campaigns by provision of information, education, and communication material. So this is dengue epidemic prevention, control and management program. The government of Punjab was grappling hard with the most serious dengue fever epidemic which erupted enormously in various cities of the Punjab, primarily in Lahore. The dengue outbreak in Punjab took a serious toll. In the very context, the PRMP was directed to get tailor-made training courses designed under its time-tested partnership with Asian Institute of Technology, Bangkok, Thailand. And this came up with a professional training course, dengue epidemic Epidemic Prevention, Control and Management, which was held in Thailand from this in December 2011. Then we have Dengue Expert Advisory Group. Dengue epidemic started in 2011 in Pakistan. Then Dengue Expert Advisory Group was formed, and it is primarily concerned with the clinical management of dengue and is comprised of a group of clinicians who work to analyze the data of previous years. In the light of this analysis, we develop treatment protocols, guidelines, and give strategic advice to the provincial government of Punjab on how to improve the dengue control program. Recent updates. This is an recent article on mosquito sterilization offers new opportunity to control chikungunya, dengue, and Zika. According to it, this is a technique that sterilizes male mosquito using radiation will soon be tested as part of global health efforts to control diseases such as this chikungunya, dengue, and Zika. The sterilized insect technique is a form of insect birth control, and the person involved rearing large quantities of sterilized male mosquito in dedicated facilities and thus releasing them to mate in the wild. As they do not produce any offspring, the insect population declines over time. So this is the very important and recent technology that's going to be implemented worldwide. Now coming on to MCQs. MCQ number 1. Dengue is a viral infection that causes fever, aches throughout the body, and severe cases bleeding in multiple areas. How is the dengue virus transmitted? By person-to-person physical contact, by touching animals, often pets that are infected with the virus, through tiny droplets by when infected person coughs or sneezes, via mosquito that carry the virus and bite people.
D.
Yes,
D.
the right option. MCQ number 2. The following signs and symptoms manifested by patient in the febrile phase of dengue fever except high fever, rash, petechiae, severe GI bleeding.
D.
Yes, D is the right option.
D.
MCQ number 3. A 25-year-old man presented to medical OPD with complaints of severe body aches, along with high-grade fever and retroorbital pain for last 5 days. Which of the following tests would a doctor would recommend him being suspicion of dengue fever? PCR, NS1, virus isolation, serology test, IgG, and IgM.
D.
Yes, B is the right.
D.
NS1. Yes. MCQ number 4. In the primary dengue virus infection, a low titer antibody response is observed with IgM first produced and IgG detectable in the end of the first week of illness at low titers. A low titer antibody response is observed with IgG first produced and IgM detectable in the end of the first week of the disease at low titers. IgM is detectable throughout the acute illness starting from day 1 of infection. IgG is only detectable in secondary infection.
A.
Yes, A is the right option. MCQ number 5. The first dengue vaccine, Vaccia, was developed by Sanofi Pasteur in 2015, but still is not commercially available in many countries, and its use is limited because of high cost, low effectivity, increase the risk of severe dengue in those who have not been previously infected, less safety in previously infected individuals.
C.
Yes.
C.
Yes, C is the right option. MCQ number 6. A 12-year boy was brought to PEDS OPD by his parents with active complaints of vomiting, retroorbital pain, fever, and body pain for last 4 days. His lab investigations showed thrombocytopenia and NS1 positive. What would you not recommend him as a doctor to relieve his symptoms? Acetaminophen, paracetamol, ibuprofen, oral rehydration salt.
C.
Yes,
C.
yes, because it is one of the NSAIDs which is contraindicated in dengue fever. MCQ number 7. Which of the following is not eligibility criteria for dengue vaccine? Age 9 to 16 years, people who have been infected previously, people living in endemic areas, people living in areas where there is ongoing outbreak.
B.
No, D is the right option because it is not the eligibility criteria, or these three are the eligibility criteria for dengue virus. MCQ number 8. Dengue is a viral infection transmitted to humans through the bite of infected mosquitoes. Which of the following is not true about dengue fever? It is found in tropical and subtropical climates worldwide. Dengue virus has 4 serotypes. Infection with any of the serotype does not make an individual immune to other types. Dengue is less severe in previously infected person. A single individual can be infected 4 times.
D.
Yes,
D.
is the right option because it is very severe if a person is already previously infected. MCQ number 9. Which of the following is not true in case of a pregnant or lactating mother infected with the dengue virus? Pregnant lady can transmit the infection to her baby. There is no risk of any harm to the fetus. The risk of transmission to baby through breast milk is low. There are chances of fetal death or premature babies.
B.
No, B is the right
B.
option because it causes fetal death and premature babies. So B is the right option. MCQ number 10. A 40-year-old lady presented to medical emergency with complaints of bloody vomit and nasal and rectal bleeding. She was giving history of severe body aches and high-grade fever for last 4 days. Her vitals were normal at the time of presenting to hospital. Her tourniquet test was positive. CBC showed 100,000 platelet. Which of the following would she be suffering from? Probable dengue, confirmed classical dengue, dengue shock syndrome, dengue hemorrhagic fever.
D.
Yes, D is the right option because she's suffering all this is the characterization of dengue hemorrhagic fever. This is the MCQs and thank you.
Thank you very much, Dr. Meha. Very, very nice presentation. Please stop the recording.